My name is Andrew Finlinson. I'm a student of physical therapy working under the direction of Dr. Stradling. And here it looks like we have a neuropathic ulcer. The patient came in, he was a 62-year-old male with uncontrolled hyperglycemia, a few different other comorbidities present with hypertension, hypercholesterolemia, obesity, COPD, a few other things. His diet is unregulated thus far, and he's been referred for generic rehab needs as well as wound care. So we took a look at his wound that he has on the bottom of his foot, and it looks like we have a stage 3 full thickness wound that's close to a stage 4. Just based on the pictures and the measurements, it is 3 centimeters deep, which initially led me to believe that it was going to be a stage 4, but we don't see the presence of any muscle or ligaments or bone in the area. So it looks like it just got to the subcutaneous layer and is there. So looking at the wound in the bottom left picture and the top right picture, we're seeing slough, and it appears to be on the lateral proximal portion of the wound, covering about 55% of the wound area, and then granulation covering the lateral and distal portions with the rest of that. The etiology of this wound is likely from the diabetes that he has and the incurring neuropathy that comes with that. So what we're going to want to do with this a little bit is test the sensation of the foot using a monofilament test, as well as doing an ankle brachial index to see the blood flow in the area, just to see if he's getting oxygenation there, because that will greatly affect the rehabilitation of his foot. The etiology of the wound, as I mentioned, probably has to do with the diabetes that he has. He most likely stepped on an object that opened the wound up, leading to a potential infection. And the reason that I believe that this is infected and not just a typical neuropathic ulcer is because, first off, the shape of a neuropathic ulcer is typically just round in shape. And this one is not round. It looks like it has some edges on it, and it's longer on other sides. The other thing that leads me to believe this is the drainage that we see in these pictures. Typically, neuropathic ulcer will not have a significant amount of drainage, but there is a lot of drainage coming out of this wound, which would come about because of an infection. We'd also want to look for other signs of rubor, calor, dolor to go along with the drainage that's there. A few barriers that will go along with this wound that could impact healing. One would be like his obesity, the hypercholesterolemia, just these different comorbidities that he has, as well as his diet that is unmonitored. That will affect his metabolic system quite a bit. But just on top of that, if he does have the need to ambulate around his house or within the community, he won't be able to do that as effectively, especially with this wound in his foot, and he won't be able to use a TCC at the moment because of the infection that he has. He also isn't taking care of his diabetes very well, and he most likely does not have proper footwear, which will impact his feet and recovery. He likely has neuropathy in his feet, as well as vascular damage, and the blood vessels depend on the neural regulation for normal function. Then a couple things that I would do to be able to help this patient with the wound is to be able to remove the slough and get rid of the infection to start out with. I would do one of either two things. Both would need a physician's prescription. One is the Sharps debridement to remove the slough from the wound and some of the calluses that have formed in the peri-wound, as well as it looks like there's some of the folding on the outside of the wound as well, and that's the epibole that's found on the proximal medial side of the wound. But if I'm unable to see the entire wound area, I would use an enzymatic debridement, and this is less painful than the Sharps debridement with necrotic tissue, but they're both recommended for infection. So both techniques would be appropriate in this case. It looks like the physician also recommended the use of Dakin solution for cleaning the wound, followed by betadine soaked dressing. This could potentially help. The Dakin solution is recommended for infections, to prevent infection, and the betadine also works with mild skin infections. So this could potentially help. What I would do in this case as far as dressing options would be using an alginate dressing. So I might begin with a Dakin solution to prevent further infection and use an alginate dressing to maintain the moisture in the area, as well as allow for some of the breathability. So the alginate would come in multiple different forms. I would use the ropes to fill the tunnels that are present here, which I didn't mention earlier, but the tunnels often will accompany a stage 3 full thickness wound, and we see those at 6 and 12 o'clock in this wound. So the ropes will be really important to help there, just to get rid of any potential infection in there. And then I'd use an alginate sheet to cover the superficial aspect of the wound and absorb the drainage. And alginate is recommended for full thickness wounds with a lot of drainage and infection. A couple things I'd like to discuss with the patient as far as education and goals go. I would encourage him to really regulate his diet and maintain a food log, just keeping track of the things that he's eating, as well as doing daily foot checks. This will be really important to prevent further issues in the future. To maintain this wound, make sure it's recovering properly. And then I would discuss also with him in the future, once we get rid of the infection, the possible use of a TCC to take the pressure off of that wound and spread it throughout the whole foot so that he has the ability to ambulate and not put excess pressure on that wound.